Dysplastic hip is quite common in Asia, and certainly in Japan. They say that 90% of the patients they operate on have some form of dysplasia. And in my own personal workload, I think it's about 30% of my patients have some form of dysplasia that's caused an abnormality to the hip. Really, in our part of the world, doing a hip replacement for primary osteoarthritis is quite rare. Hoagland studied this together with Lau. They compared an American population to a Hong Kong Chinese population, and suddenly they discovered that the Chinese have much more anteversion in the hips. Maybe it's because of our custom of sitting cross-legged, but I also think that there's just some differences between the two populations. At the same time, they also discovered there were significant differences in measurements of the head, neck, and the proximal shaft in the average Caucasian compared to the average Hong Kong Chinese person. When Hoagland went on to study subjects presenting for hip replacement in San Francisco, and given that San Francisco is quite a polyglot community, he discovered that Asians certainly had a lower incidence of THR, and that rate was about 10% of the white population of San Francisco. So he went on to study the difference between reasons for operation comparing Kobe to the U.S. population. So they just took 200 consecutive X-rays from patients presenting Kobe University and Massachusetts Hospital. And when they compared the indications of surgery, you can see here that the two lists hardly actually cross. So the largest indication for hip replacement in Kobe, when you've taken out all forms of inflammatory arthritides, would be either CDH or DDH. Or some form of superolateral OA, which again is a reflection of dysplasia. So probably when the Japanese surgeons say that dysplasia is the commonest cause of hip replacement in Japan, they are absolutely right. But the thing about hip dysplasia is that many of these patients have had it, they've all had it from young, and they've had increasing pain and discomfort, and they've lived with it. And so when they present, the last patient presented to me with hip pain. She thought she had cancer. She was really worried. When I said, well, no, it's not cancer. You just have dysplasia. She said, oh, fine. I'll see you next year then. They're okay with it. They're used to these stiff hips, and they're quite happy to continue without a hip replacement. So you can pretty much manage them conservatively for a very long time. And I've had patients on my books for 10 years without having a hip replacement. But when you do decide to operate, you have to realize that many of the patients you operate on are quite small. And so when you plan your surgery, you need to consider size. On the same day as I operated on this lady who was small and dysplastic and required a very small total hip replacement to be inserted, I also operated on this Caucasian gentleman who obviously didn't have dysplasia but needed a hip replacement. And you can see that the kind of it's the same implant, but it's a different size. And basically, you've got Asiatic sizing for these smaller implants, and that really helps a lot. So if you do decide to operate, the acetabular anatomy is often distorted. You can see that in many of these patients, there is a very much larger medial osteophyte, and of course, the femoral head has been displaced laterally. And in these patients, if you think that you're going to use a large head to get stability, I think you're going to be very mistaken, and you're going to end up with a lot of problems. And this is just an example of what might happen. Clearly, as Charlie said, it's important to medialize the cup in these patients. And so you really need to dig into the acetabulum to get the cup seated properly, like this. So when you look at that closely, you will see that, in fact, you have to dig right into the so-called weight-bearing surface of that acetabulum. And if you don't realize that how much you actually have to reformat the acetabulum, you're just going to get it wrong. And using reamers does not help you at all. Using reamers is just going to help you to get it wrong. You actually have to core out that superior medial corner in order to get the implant in nicely. So you use osteotomes or chisels or whatever it is that you get to get that bone out. In all these patients, they've had the problem for many, many, many years. So when you operate on them, you find, in fact, that the hip is very abnormal and the capsule is very tight. And if you leave the capsule in situ, you're going to have problems balancing that hip. In addition, as we said before, the acetabulum and the femoral neck are anteverted. And so when you position the implant, you have this big decision to make. Are you going to use the same anteverted position? Or are you going to go for a more normal position? And for this, I'd like to refer you to this article by diodedema, which I think is probably the best article I've ever found written on component position. And basically he says that if you put it in at 45 or 55 degrees of cup inclination and about 30 degrees of antiversion on both sides, you're going to get a very stable hip. No matter what kind of femoral head you use, whether it's a 22 millimeter head or a 32 millimeter head. That's what I do most times. Using a small head is not such a bad thing. I mean, this is a study that was done by Kim, YH Kim in Korea. And basically what they did was compare different articulating surfaces and different femoral head sizes. And you can see really that if you use metal on poly, you're going to get the least wear and the best long-term results. And this shows in many, many publications and journals. So my personal take on this is that cement implants fit the patients well, and you can always get a cemented implant to fit the patient. If you try to put a cementless implant in, you're likely to end up with a lot of problems, and probably you have to get custom implants for these patients, and they're not going to be so happy with the long-term results. So in summary, replacement of dysplastic hip requires slightly different thinking. There are, many of the so-called accepted truths of hip replacement may not apply to these patients. Familiarity will help you to make your surgery better. You need to plan well, especially when you consider size. I would highly recommend you use some form of cemented polystapled stem with Asiatic sizing. Small head sizes are appropriate for this group of patients. And if you're going to use a cup, I would also recommend a cemented flange cup, which in my experience has never failed. Thank you very much.